Good afternoon, everyone. Thanks, Nina, so much for the kind introduction and for inviting me here and the beautiful plague. Okay, so today for the next hour or so, I want to introduce you genomic profiling and big data machine learning that drive precision cancer care. This is what we do at Children's Hospital of Philadelphia. We do comprehensive genomic profiling for cancer. We do chromosome analysis, that's what you can see there. And we do FISH, and both of them are still standard care for leukemia. And we also do chromosome microarrays. So although we do much less than what we used to, because we can build some of the copy number changes into our next generation sequencing panel. But if it's needed, we can still do that. And we also do single gene tests, for example, use MLPA for copy number changes, and or do Sanger sequencing, and that will detect specific mutations in a gene. We can customize the test for the patient needs. And for example, if a patient had a novel fusion, we need to trace the fusion transcript. We can use clinically validated technology, just swap the primers and to trace the patient as the patient goes through the clinical treatment. We can also do targeted sequencing for the confirmation purposes for patient or for family members. We also build in our pharmacogenomic testing. We are the only lab, clinical lab, offer NAT15. And for those who treat ALL, you use 6MP, and this is one of the tests to go along with TPMT. And we also offer TPMT as well. And all the patients in our lab will be profiled for those. And of course, we do next generation sequencing. Our next generation sequencing could be panel-based, and that's the majority of our test. And that could be tumor normal paired analysis or tumor-only analysis. And we also do germline testing for cancer predisposition diseases or for bone marrow failure syndromes. And those patients also have tendency to develop cancer, specifically myeloid diseases. As we know, cancer is a genomic disease, and it can be caused by mutations in the genes. That could be pointer mutations, it could be translocations, for example, BCR-ABL caused by 922 translocation, and it can be also copy number changes, and such as what I showed here in neuroblastoma with emic amplification, and it can be epigenetic changes. And so it can be methylation change and in specific genes or deacetylation changes. It can be also translation related change or transcriptome change. And in general, cancer is a constellation of different genomic mutations. And some of those alterations could be driver mutation, they are recurrent. So those are, in general, a biomarker will pay a lot of attention because they can be the target for therapies. What are the significance of biomarkers? So we call those genomic alteration biomarkers. Why they are biomarkers? They can be used for diagnosis. For example, if you see a KIAA 1549 BRAF fusion, you can diagnose a patient with pilocytic astrocytoma. If you see FLT3 ITD, and that's a poor prognosis for a patient with AML. But sometimes those biomarkers may have more than just one clinical significance. For example, in 2017, in the middle of 2017, FDA approved midostaurin to be used for AML patient who has FLT3 ITD. So this marker not only have prognosis significance, but also have therapeutic significance. And some biomarkers can be used as for the targeted therapy. For example, JAK2 V617F if you identify those patients in myeloproliferative neoplasm, and then you can use JAK2 inhibitors for those patients. And that can be used for PH like ALL with JAK-STAT pathway activation as well. I will give some examples there. I mentioned some of the biomarkers, they have multiple different clinical significance. For example, PMA-RARA fusion, and it has all three clinical significance. If you see this fusion, it's pretty much diagnostic for acute promyelocytic leukemia. The prognosis is good, provided you treat them appropriately. You have to treat them right away. And it's an indication that patient will be sensitive to all trans-retinal acid. So all of those, even though the mutation, we consider that's not good and that cause cancer, but if we identify those, we can turn them into a biomarker, which our patient may benefit from it. So because cancer is not simply caused by one mutation in one gene, so we need high throughput technology to allow us to be able to detect all the mutations possible at the same time. So next generation sequencing now it's become the mainstream technology for the cancer genomic profiling. And you can use a smaller platform like this is a PGM, this is a MySeq, and you can also use Proton, which is larger capacity, or you can use HiSeq, and now there's a NovaSeq, which has a huge capacity. You can run many sequences at the same time. So now we've figured out the way we can pull all the tumor testing, put in one run, and we run one time a week. So and put all of them into our NovaSeq. So it takes a lot of time to normalize those, but that can be done to reduce the cost of those tests. These are the main technology we use for the cancer profiling. And on the left side is the technology we use for DNA-based testing. And we design our panels with the region of interest. Those are the genes we're interested. All of those genes are collected together with our oncologist. And then we also put in SNPs into our panel. This will help us to have a backbone in the whole genome and serve as a very low density array and to help with the detection of copy number changes as well as ploidy change, which is extremely important in pediatric cancers. We also build in SNPs for ID check. And as we all know, for next generation sequencing, we barcode each specimen, we put them together and mix them together doing sequencing. And then we demultiplinize them. So after you demultiplinize them, you need to make sure and the patient of A, the data is really from patient A. And so at this time, SNP check is very important. So we build those SNPs into our panel and we use bioinformatic way automatically match them. If they are not matched, and that will be automatically flagged. On the right side, this is our RNA-based testing for fusions. We use ENCODE multiplex PCR, and it's like a one-sided PCR. This is an applicant-based technology. So we design specific primers for a major translocation partner. And as you can see on the 3', it's a common primer. And so if there is a fusion, and this sequencing is going to sequence through the breakpoint, and then you align the sequence to the human genome, you know what the mutation, what the fusion genes are composed of, and what it's involved in that fusion. So the somatic panels are mainly developed by Drs. Lin and Drs. Chang, and they are right now, Lin is a fellow in our lab, and Dr. Chang went on to a company. And This is our hematological cancer panel that include 117 genes, and that associated with pediatric and adult hematological malignancies. And as you can see, the average sequence depth is 1600. So for that depth, and you will be able to guarantee to detect 5% of mutations with a 5% allele fraction. When we did our dilution study, we can actually get to about 1%, but 1% is a little bit iffy. You may or may not detect it. So we set up our frequency at 5%, but we do detect all no mutations. So we know those hotspot mutation in our cohort of patient, and that is 3%. That for the cutoff for those, it's 3%. And this is our solid tumor. This is our solid tumor panel that include 238 genes. So we cover all the coding regions and the exon intron flanking region. And in addition to that, we also cover no intronic mutations. And if we know there's an intronic mutation, we put probe there, we capture those, and so that we won't lose those. Because we put in the SNPs, that will allow us not only to detect SNVs indels, it's also allow us to detect copy number changes. And the panel is also can detect loss of heterozygosity because we have SNPs built in, and this is also validated in blood, bone marrow, fine needle aspiration, ascites, FAP, fresh or frozen tissues, and we validate the test in all different tissues. Our fusion panel, that include 110 major translocation partners. Those translocation partners will detect over 600 different fusions. And we know this is what been reported already, but the fusions we have detected, if we count each fusion as one, let's say I detect the ETB6 RUNX1 100 times, we still count as one. More than 50% of the fusions were rarely or never be reported before. We have a way we can evaluate if that fusion is clinically significant. And all the fusions, when we detect in our lab the first time, we will Sanger confirm them. We use RT-PCR and then we run Sanger confirmation, even though with plenty of reads, and this is for our QC purpose. And we also do Sanger confirmation if the reads it's pretty low. So we want to make sure what we reported is really the case, because sometimes you get a minor clone, and so you may have lower than what your standard core reads it's set up. So the panel used this ENCODE multiplex PCR technology, and the panel is, works on all different tissues. We also validate the test, even though it's RNA-based test, and we validate the test on FFP samples. So we also have a hereditary cancer panel. I discussed that a little bit at the earlier grand round in genetics. The reason we have that is in pediatric cancer, at least 10% of the patient had underlying cancer predisposition. So for those patients, we may need later on or at the beginning and to have a panel available for those patients and their potential at-risk family members. So this panel, we recently mixed together with bone marrow fenil panel as a one large panel. And there are some genes overlap, so that's why we did that. And in addition, the cost for sequencing has dropped dramatically. So you are a little bit larger panel, and it actually increase your copy number accuracy a little bit more, number one. Number two, and if you need to look at the different genes, and if you need to look for not a traditional cancer predisposition genes. And you may actually do that without additional sequencing. So the sequence depth for that is about 650. So this will allow us, even though we can still detect about 1%, but we call our lowest detection limit at 10% because we're looking at the germline. But for this panel, for patient who has, for example, a bone marrow failure patient with Fanconi anemia, if they early stage, they get into MDS, and we will still be able to detect them. And we included a lot of intronic mutations into this panel, because we know, for example, GATA2 has an intronic mutation between exon 4 and exon 5. So we targeted those regions, captured those for specific mutations. This panel also allows us to detect SNVs, indels, and copy number changes, and also germline absence of heterozygosity. The panel can be divided into small panels if you know exactly which panel you want to run. And then you can also ask for the comprehensive panel that include all the genes. We have a group of bioinformaticians, and they build an in-house bioinformatic pipeline for us for next generation sequencing data analysis. And this left side is mostly provided by the machine. If you have a NovaSeq, HiSeq, that will generate those data for you. And then in the middle part is your secondary analysis. So you can see we have different pipeline for somatic changes, and because they're a lot more complicated. So we use 5 different cores and to detect different detect the different mutations. As you can see, we even use a specific PINDAL to detect tandem duplication. But for germline, it's a little bit easier, and it's not as complicated. So we use 3 different tools to call. After the call, and it will go through our internal pipeline to go through the filtration, and we also use human genome mutation database. We use Cosmic, and which we pull no mutation aside, not go through the filtration, and the rest of the data will go through the filtration. But unlike the germline testing, somatic testing, and you are going to encounter a lot of variants. Even though some of them is true, but a lot of them could be artifact that caused by your sequencing or caused by the machine. It can also caused by PCR. When you do PCR amplification, polymerase enzyme is going to make a mistake. So at the beginning, we have to look at a lot of variants by our genomic analyst. And after a while, and we look at that, I said, can we do something and through our data, through machine learning, we can reduce the human time. And with 200 to 300 variants per case, and you need one experienced genomic analyst to do a whole day work, and it may or may not even finish. So we figured after we start to have 50 cases, and our very smart genomic analyst, a PhD, and start use a spreadsheet and to do what we call variant screener. And those are the very early stages. It's not machine learning yet because we don't have enough data. Once we have a few hundred of cases, we got thousands of variants. And at that time, we said, well, we need to do something. So we have one of our bioinformatician and one of our genomic analysts, and they start a project called AIQC project. AI is artificial intelligence. So, but we're not there yet. We'll just use that similar idea in a proportion of our test. So this is started with what we call, this plot is called principal component analysis. So you when you do your variant analysis, you look at the different features. For example, you look at the strand bias, mapping quality, allele frequency, you look at all of those. But we know one of those components is going to give you enough confidence to call if this variant is false or if this variant is true. So we did this analysis. The yellow is artifacts, and the blue, they bioinformatically call positive. It basically means it's true variants. As you can see, even though majority of them can be separated, but there are good overlap between true variants and the false artifact. So we need a way to separate them out. So the way to separate them out, we pull out all the features. We identified, this is just a machine learning, how you set up your training set and then your test set. And so this is the algorithm we used. So we picked these 9 features. So that include your coverage depth, your strand bias, allele frequency, mapping quality, similarity to normal, similarity to abnormal. I don't really understand all of those formulas, but our bioinformatician knows. So they come up with this algorithm. First, they use over 3,000 different variants, and they look at all different features. After that, and they try different validation, use different set, and that's another 2,000 some variants. And then they pick the one which is what we call the winning model. And this winning model, and we will use as a test set. So this test set, it's almost 550 variants. It's pretty much analyzed by Dr. Wu and Dr. Schubert. They are very, very experienced not just bioinformatician, the genomic analyst. They are so good and so quick and analyze those data. So they look at all of those, sorry, it's too automatic. Out of that 5,000, almost 5,500 variants, you can see 99.3% with this algorithm. And their analysis, their manual analysis and the machine analysis is concordant. So that only leave about 0.7%. So 99% of the variant, we don't really have to look. So this is based on the scores, and they give us score of 1, it's true, and 0, or it's false, and 0.1 and 0.95 is the score. So whatever in the middle, we'll look at them manually. So that drastically increased our turnaround time for each case. Once the variants identified, and we categorize those variants based on the AMP, ASCO, and the CAP, ACMG guidelines. The guideline based on clinical significance, and to put those ones with clinical evidence as tier 1, and those are variants with strong clinical significance. For example, those variants will predict response to FDA-approved drug, or those variants will be in the professional guideline and to call and to make a diagnosis or to stratify the patient risk. Tier 2 will be those variants with potential clinical significance that include variants qualify patients for clinical trials, for investigation drugs, and or less important supporting diagnosis or prognosis. Variants with significant allele frequency in the general population and with no reported cancer association will be benign or likely benign. And variant we don't have enough information will be variant of unknown significance. We report tier 1, tier 2, and tier 3, and we don't report tier 4, which is benign. And tier 3, we only report them, we don't do any interpretation. Because we don't really know, and there is not enough evidence there. Tier 1, tier 2 are the ones we focus on our report. We report them based on the clinical significance in a descending order. And the most important ones, it's always at the front. And we also have the first page will have summary of our finding and the summary of interpretation, and detailed information will be at the following pages. This is our first summary we published relatively recently out of a little shy of 500 patients. As you can see, we have a positive yield of over 80%. And if we look at the different variants, tier 1 variants, most common one is fusion, not surprisingly, because the fusion is either diagnostic or they may be therapeutic or prognostic. So, but if we go to see a tier 2 and you see SNV, which is single nucleotide mutation or indel, and copy number changes will become more. And when we look at the clinical significance, therapeutic significance due to based on the diagnosis. Sometimes we change diagnosis, and this is about 20%. We have a QC, internal QC study, and to see how our genomic profile changed the clinic practice. So there are 20% of those. On the therapeutic side, therapy changed based on prognosis is about 40%, and the potential targeted therapy is also about 40%. So, and you can see the clinical significance. I will give some examples. And because of that, you diagnose patient right, and the patient treatment is right, and the patient may stay in the hospital for a short period of time instead of a long time. And they may get a complete remission earlier. And this is abnormal rate by different tumors. So this is this publication is first authored by two of our junior faculty. Leah is a molecular pathologist, and Suzanne is a young pediatric oncologist and also focus on cancer predisposition. And this figure shows the circles plot of fusions we identified out of those a little bit shy of 500 cases. You can see, and certainly solid tumor has all different kind of fusions. And this is CNS tumors, and then of course they are most the common ones. It's in the ependymoma or in the pilocytic astrocytoma, and so they have less lines, and the hematological malignancies and also have a lot of fusions. This figure shows the mutation spectrum of pediatric tumors, include all different tumors there. As you can see, and the highest mutation rate is TP53, no surprise. But if you look into detail, and solid tumor and the brain tumor had non-CNS solid tumor and the brain tumor had much higher mutation rate in TP53. In the hematological malignancy, it's a little less. But in hematological malignancy, the most common mutation is KRAS and BRAF and NRAS. And this is not surprising because ALL is the most common pediatric leukemia. If we look at a different mutation in specific category of tumor, this is a non-CNS solid tumor, and you can see TV53 win the gold medal, and the EWSR and FLT1 fusion, it's the second most common one. That's just because we have more of the even sarcoma patient. And this figure shows in brain tumor, CNS tumor, the most common one, of course, is KIA 1549 and BRAF fusion. And most of the pediatric brain tumors are low grade. And as the pilocytic astrocytoma, this is the most common one, which gives patients a very, very good prognosis. And BRAF mutations, the second one, TP53 and H3, F3A follow of those. This is in leukemia, and NRAS, KRAS mutation and are the winners, and ETV6, RUNX1 fusion and follow those two mutations. And of course, we have a lot of long tail of different mutation and fusions. look at the fusion data, and this is a summary of our a little over 1,300 different pediatric tumors. As you can see, pediatric tumors has a lot of higher fusion detect rate, and they don't have as much mutations compared to adult patient. We average out a little less than 1 mutation per tumor, but fusions is almost twice as much as adult cancers. And this are pulled out from our data of adult patient. We don't have a lot of them. We have just 100 of cases. This is by clinical significance. You see all of those fusions are diagnostic, and then they are very cancer specific, and they are prognostic very high in CNS tumors as well as in leukemia. And in therapeutics, of course, CNS tumors gets the highest. Since FDA recently approved 2 drugs for track positive solid tumors, and that include both adult and pediatric solid tumors, we summarized relatively recently, I think that was February, we summarized our track fusions. We identified 25 track fusions, and of course, most of them are in thyroid, papillary thyroid cancer, but it's also in other cancers. And as you can see, now we have about 30 or 31 different track fusions now. The reason I mentioned that, and I want to show you an example how we use that to treat patient. But my first case I want to discuss is how biomarker to help us for targeted therapy. And this is a 12-year-old boy with high-risk pre-B ALL. And he was on very high BALL COG clinical trial therapy. You can see on day 8, his blast is still 43%. At the end of induction, day 29, 40%. Apparently, patient did not respond to this very high ALL therapy. And this is a chromosome analysis. And you can see by nomenclature, you know how complicated chromosome changes are associated with high risk, we know. We did BCR-able FISH because of the chromosome 9 change, and there is no involvement of BCR-able. So it's not BCR-able positive ALL. And at the time, that was 2015, and my fusion panel was not live yet. So I'm in the process of validate that fusion. So the specimen was sent to Foundation Medicine and for RNA-seq, but it didn't work twice. So we had no other choice. So we sent to a research lab for RNA-seq, and the result is also negative. And we did a microarray. So our genomic analysts, again, I have to give them the credit, and they pick up this very, very tiny part of JAK2 duplication. So it's very small, it's half of the gene. And so from that, I kind of know where the break point is. So I said, okay, use this primer, and which is exon 8, 9, and 10. Go to your junk pile and of RNA-seq to see whether you can fish out something. So they found 3 reads. The 3 reads is JAK2 with a gene, GALG-A5, and never even knew associated with cancer. So, and I was, validate the panel. So I put this case into our next generation sequencing panel. And here we identified a fusion between GALG-A5 and JAK2. And this retained the tyrosine kinase domain. And this fusion activated JAK-STAT pathway. And because of that, JAK inhibitor, ruxolitinib, was added to this patient treatment. So we designed a specific real-time PCR test specific for this fusion to follow the treatment response of this patient. So you can see, and after a couple cycle of treatment, and the transcript, it was undetectable. But unfortunately, the flow cytometry always identify somewhere around a little below 0.1% or around 0.1% blasts. So we discussed this patient as a group, and Sarah Tation's lab is doing some research on that. So we thought this might be a clone which does not have that fusion. And that clone is CD19 positive. So, and we used the CAR-T for that patient with CD19 CAR-T, and that just wiped out the residual disease. And then we discussed what we do with the patient. The patient is in complete remission, but he does have a complete matched sibling. Should we do bone marrow transplant or not to do it? It was a pretty tough decision because bone marrow transplant also have some side effects. So, but finally we made the decision with the family. We feel it's so hard to get the patient in complete remission. We don't know if the patient relapse, could we bring him back to complete remission? And since there is a complete match bone marrow from the sibling, so the group made the decision and to give the patient bone marrow transplant. And the transplant was done in 2016. Now it's almost 3 years, and the patient has been good. And ever since, this family actually thanked Cancer Center so much, and they did a video. They set up a foundation to sell cookies, lemonade, to raise money for cancer research. I showed the video to the whole lab. Everybody was moved, and how much, and work with the oncologists and work with the patient, and that do make differences. And Sarah Tation's lab did the translational research, injected the bone marrow to mice, and then they treat the mice with ruxolitinib and or vehicle. And as you can see, and treat it, and you see the blasts and drop drastically. And this is the size of the spleen after sacrifice the mice. And Young as one of our clinical oncology fellow. And so, and she worked in Sarah's lab, and finally we published this fusion. And the other therapeutic significance I want to talk about is NTRK fusion. This is a solid tumor case, and this is a 6-month-old male with non-significant birth or medical history. And he presented in our emergency room with a big mass on the left arm. So histology suggests this is some kind of neoplasm, and it could be a sarcoma. But there are a lot of differential diagnosis that can happen. But to rule out, this could be infantile fibrosarcoma, and we have a ETV6 breakup part of fish there, because that's most common as ETV6 and TRAX3 fusion. So we ran that fish, which is negative. And then this is when the MR showed the mass on the left arm. And this is in April, this is in May. You can see it grows very quickly. And then we ran our fusion panel, and certainly we not just using, we did our DNA panel as well. And we identified this SPECC1L and NTRK3 fusion. This has been reported once in an abstract in a patient with infantile myosarcoma. And the family was given the choice and to have surgery or to be on targeted therapy. Bayer provided free drug, and through their program called TRACACCESS. So the family worry about such a young kids to have a surgery. So they opted to go through the targeted therapy. And as you can see, this is April. This is May. And we started to use the drug in June, and now you can see, and the tumor is drastically shrinked. And the biomarker can also be used for prognosis, for risk stratification. For those who treat pediatric ALL, we know there is one type of pediatric ALL and has a high hyperdiploid genome. And that high hyperdiploid genome is an indication of a good prognosis. It's about 20-ish% of pediatric ALL. But there is another pediatric ALL called hypodiploid ALL. And hypodiploid ALL is about 1 to 2% of pediatric ALL, but the prognosis is really poor. And some of them may have hypodiploid, and some of them could be near haploid. Sometimes the genome may duplicate it, and that is the DNA duplicated, but cell did not divide. And when you run chromosome analysis and they have the chromosome number mimic high hyperdiploid ALL, but the prognosis is still poor. So, and this is the COG study showed the lower the chromosome you have, the poorer the prognosis. Unfortunately, and histology will not be able to tell those two ALL apart. And flow cytometry is also going to be the same. And you're going to have CD19 positive or CD22 positive. Cytogenetically, you may or may not detect it, depending on whether they divide or the cell divide, or whether there is additional chromosome loss. So because we have SNPs built into our pipeline, so, and you can actually separate them out. The top plane, and this is a log R ratio, and this is a patient B allele frequency. This is a control B allele frequency. So as you can see, in this case, there are 3 copies, there are 4 copies, there are also a deletion, which means 1 copy. And you focus on the chromosome with 2 copies and look at whether there is a heterozygous SNPs. Whatever is in the middle is AB, that's heterozygous. So this is high hyperdiploid ALL. And when you go look at a duplication of hypodiploid or near haploid ALL, and this is a near haploid ALL, and the copy number change, there is not, and most of the chromosomes is 2 copy, and there are 2 chromosomes, chromosome 14 and 21 has 4 copies. When you look at the B allele frequency, the whole genome except the chromosome 14 and the chromosome 21 showed mosaic loss of heterozygosity. So that will tell me, and this is actually near haploid ALL and through a duplication of the genome. So whatever originally has 2 copies, that is chromosome 14 and the chromosome 21, and now becomes 4 copy. And because it's 2 homologous chromosomes, so B allele frequency is in the middle. But the rest of the chromosomes, and they were 1 copy, now it's duplicated. So they completely lost the heterozygosity in those chromosomes, in the tumor. And so that's why you see this split signal of all the B allele frequency. Because it's a mosaic, there are some normal tissue mixture, so you only see mosaic. So this case is hypodiploid with doubling of the chromosome. And this will help us to stratify the patient, and with very high intensive treatment for hypodiploid ALL and standard treatment for high hyperdiploid ALL. And biomarkers also can help with precision diagnosis. So this is a 16-year-old female present with a mass on the right mandible. So she went to see the dentist. She thought maybe it's some problem with her teeth. And the dentist said, oh no, this might be a tumor. You should go to see an oral surgeon. So the oral surgeon knocked off 3 teeth and then did a biopsy. This was 2014, which I have not moved back to CHOP yet. And they did, the patient was first seen at outside hospital, and they came to CHOP for second opinion. And this is the mass where the mandible mass is. So at CHOP, and we did another biopsy. So we did a fish with EWSR breakout part probe. And you can see there are 3 copies. One of the 3 copies had a split. But this result was not duplicated at Memorial Sloan Kettering. So everybody said, okay, this is malignancy. But what malignancy? Nobody knows. Because this fish result, this was diagnosed with atypical Ewing sarcoma. So it was treated as a Ewing sarcoma. And of course, once you treatment finished and the patient relapsed. So in 2016, the patient came back to CHOP. And at that time, we have our fusion panel. And we profiled the patient tumor. We identified this EWSR CRAB-B3L3 fusion. Yes, the fish was correct. I think what the fish ran at Memorial Sloan Kettering could be a different block, and maybe it just didn't have this. And we all know there is a tumor heterogeneity there. And then this is EWSR exon 7 fused with CRAB-3L3 exon 4. This was a novel fusion, never reported before. But the fusion with CRAB-B3L family, like L1, L2, and was reported in a disease called the Sclerosing Epithelioid fibrosarcoma, or in a short SEF. And it also identified in other diseases like osteosarcoma, etc. And to make a diagnosis of SES, we performed a series of IHCs to distinguish those. And finally, and the MUC-C4 IHC showed positive, and that support the diagnosis of SEF. And this SEF is so rare, so there is not a standard treatment for that, but most of the reported therapy was a resection. If you do radical resection, make sure your margin is negative, and the patient prognosis is relatively good. So this is what we did for this patient. The patient underwent radical resection of the tumor, and we also did fibula graft reconstruction at the time. And I did have a patient picture, but because I didn't get the permission to show it outside, and so I'm not showing it here, and it looks just as a normal. And we also tested the margin, and the margin is free. So far, the patient is follow up at CHOP, and has been doing pretty well. The last case I'm going to discuss, but not the list, is cancer predisposition. And this is a 7-year-old male with no prior medical history. And he just had relatively recently, about 1 week, he had left side, the whole body weakness. And when it gets severe, he came to our ER. And we did the biopsy of this. And we also had CT scan, and as you can see, the tumor is here, and that pathology diagnosis, osteoplastic astrocytoma. Of course, this is high-grade glioma, and we did genomic profiling. As you can see, we found a lot of mutations, and this is just a tier 2 mutation at the time, and we also have other 8 mutations. I mentioned pediatric cancer don't have a lot of mutations, and this patient had so many mutations. This apparently is a hypermutation tumor. So I want you to pay attention on this too, the MSH2 and TP53, the allele fraction is very high, and it indicates there is a loss of heterozygosity there. So I was so worried about this patient might have biallelic mismatch repair deficiency. So because there are because the patient had deletion of the chromosome and as well as 2 mutations, so we ran germline test for this patient. The patient also have H3F3A mutation at the time, and this was called the tier 2. And germline showed this patient had 2 mutations. They're both germline and in his blood. And there is not a biallelic mutation there. And at that time, and the H3F3 was recategorized as a tier 1 mutation because this is a diagnostic for diffuse midline glioma, H3 mutant. And this is a new category of pediatric brain tumor. And this is a copy number change. And you can see, and this is the chromosome 2 where the MSH2 is. There is no copy number change, but there is a loss of heterozygosity there. And there is a deletion of 17p, which lead to the loss of heterozygosity of TP53. So we did send this patient to our cancer predisposition program. The cancer predisposition program pulled the patient and into their clinic and got the family history. So the maternal grandfather had MSH2 mutation, and this is a founder mutation. So he does have Lynch syndrome. But on the paternal side, and you can see this looked like a leaf-lamenting family with multiple patients with colon cancer, prostate cancer, and with a prostate cancer at 20s. So we finally rule out biallelic mismatch repair deficiency and made a diagnosis of this is a leaf-lamenting syndrome family. And this is from the paternal and the TP53 mutation, and the MSH2 is from the maternal family. And we also tested at-risk family members, the sibling, and who carries MSH2, but not the TP53. The patient after surgery was immediately under preventive surveillance. And we also have immunotherapy in our mind should the patient relapse. And we may use immunotherapy because of this is a hypermutated tumor. So in summary, we've designed large NGS panels for adult and childhood cancers and implemented a tier-based reporting system to categorize the variant and report the variants based on the clinical significance. And we also developed a machine learning system, AIQC, to help with the variant analysis and using our internal database. AIQC reduced 70% of manual variant review and increased our variant analysis efficiency at least 50%. I want to emphasize cancer is genomic is a rapidly evolving field. The genomic profiling and artificial intelligence will continue to play a central role in the precision medicine. We actually have to be very vigilant on the new development of FDA, the drugs and new development of emerging biomarkers so that we can better serve our patient. And what is the future of precision medicine? We're not there yet, but we are towards precision medicine. I think this is the central paradigm, and the big data and will serve as the platform of precision medicine. And that will allow us to do artificial intelligence through machine learning and through deep learning. And that will allow us to do different level of precision medicine. This precision medicine data will feed back to the big database. And until we have enough and big size and good quality evidence, we can then and truly realize precision medicine. Even by that time, and we will still need to continue move on and not just to test at the DNA level and RNA level, maybe at the protein level. So this is just our job. We just have to continue learn and continue move forward. With this, I want to thank all the people in our lab and who have contributed tremendously to the data I presented here. Our bioinformatics core services in our lab, and also our genetic counselor core in our lab. And last but not the least of all our oncologists, all of these panels are developed with them, and the reporting system was established with them based on their needs. And I can't thank them enough. And with this, I will conclude my presentation. And I want to thank you for your attention, and I would be very happy to answer any questions you may have. Yes, please.
Oh, thanks for the great presentation. The most impressive part to me was the AIQC part. I wonder what are the features you extracted from your data you're inputting in, because I thought it was always very difficult to characterize the VUSs based on their, amino acid characteristics or things like that. And I think at QC, you mean that like the very low fractions, and like what are the features you extracted from your data that you are able to achieve like 97% accuracy?
So this is not used to curate VUS. This is the AIQC project is to use to separate out artifacts from two variants. So VUS is a completely different story. Yeah, we have different pipeline to work on those.
In terms of reading out the artifacts, and what are the features that you're inputting into your algorithm?
I'll show you. I think I have it there. I probably ran too quickly. And so that includes like strand bios, allele frequency, mapping quality, and let me see. I have too many animations. If I get to that point, maybe this is quicker. Okay. Okay, so I can move up. Here. So these are the major features we use. See, we have different mapping qualities. The beam mapping quality, variant mapping quality, pseudo scores, which you can pull out from the database, and similarity to normal, similarity to the same batch of the same batch of the data. So these are the main features we use. And then we have a combination, because each of them may weigh differently, right? So we have multiple different, just like the next couple slides. No, wait a minute. So we use different features, and we test the different potential algorithms, and then finally pick the winning set. That would be the last one, is the winning set. Yes.
Thank you for this wonderful presentation. I was wondering, with patients who have findings of uncertain significance, is there any plan as the machine learning or this process continues, when there is a finding that may impact that patient that is discovered later, to recontact them, or how has that been addressed in your field as the field is moving so rapidly?
We do that for germline testing. We don't do that for somatic testing. And the main reason is for somatic testing, patient disease may evolve. And so what it was at the time, it may change. So we don't automatically call them, but we do that for germline variants. And if we identify something and that is, there are new evidence come out, and we consider this either way, either benign or likely. Benign, we normally don't call, but if it becomes pathogenic or likely pathogenic, and we will call the patient. And we do that on a yearly basis. We don't do it on a monthly basis. Yes.
I was confused by the last case, in which your conclusion was that this was a Lee-From-Any case, but there was an MSH2 germline.
Yes.
Right. So it's being driven by two driver mutations in one in P53 and one in MSH2.
this is my personal view, and I think the cancer predisposition, the tumor is probably caused by TP53 instead of MSH2, but MSH2 contribute to the tumor because it lost of heterozygosity and to become a hypermutated tumor.
So you're just inferring what the first mutation was.
Right. Yeah, I think it's a P53 because TP53 because MSH2, that mutation, it's late onset.
So did you indeed test for MSI, for instance, or loss of protein?
We didn't really do for this patient because we read it on a biopsy, and so that was not done. But if this patient later on relapse, and we'll probably, if they come to us, we'll probably be able to do that.
Let me ask you one other quick question. In your fusion panel, I assume you have all the fusions for sarcoma. Is that correct?
I wouldn't say 100% because it's always evolving. But I think we captured the vast majority of them, and we have the largest panel in available.
Because surprisingly, those things are not commercially available. So badly needed.
I can tell why. So I designed this panel myself and work with the company, and they make that panel for us. And I've given a lot of talks, and there are a lot of people ask them, say, we want to order Marilyn's panel. And they said, well, we can't give you Marilyn's panel because that's their property. So I did tell them, I said, okay, and I can talk to our legal department